My thesis work under the supervision of Dr. Gabriela Ilia is titled An Exploratory Cost-Effectiveness Analysis of the Pictou County Personal Empowerment Program. Nova Scotia is one of the highest rates of chronic disease in Canada, with 1 in 3 residents being obese and 1 in 3 having prediabetes or are diabetic. And if we narrow our focus further to Pictou County, the specific focus of this program, the burden is even greater here, with higher obesity rates and more health risk behaviors like smoking. So you can't fix chronic disease without addressing mental health, and you can't fix mental health without tackling chronic disease. The two are profoundly interconnected, and they create a cycle where the presence of one increases the risk of the other. This bidirectional relationship impacts quality of life and increases the burden on costly healthcare services. Chronic conditions cost Canada around $190 billion annually in combined indirect and direct healthcare spending. The cost for mental health care in Canada rivals that of many chronic diseases. Mental health care costs Canada around $51 billion annually, plus another $950 million for private therapy. Online interventions for managing chronic disease have emerged as promising, potentially cost-effective strategies for managing both chronic disease and mental health. These interventions often target modifiable lifestyle factors like physical activity, diet, smoking cessation, and mental health support. However, most of these existing programs fail the numbers test. Nearly half have no cost-effectiveness data, over a third aren't cost-effective, and the vast majority just address one health behavior. So most of these programs are too narrow. A 2023 systematic review showed that 85% of these programs focus solely on diet, and the rest targeted only exercise or exercise plus diet or another single domain of health improvement. These single component programs yield modest benefits, but they fall short without broader lifestyle and mental health support. Another issue is duration of these programs. A 2025 review showed that 40% of online multimorbidity programs lasted less than 6 months, despite evidence showing that longer interventions better support lasting behavior change. This same review also revealed that delivery style is an important factor into the success of these programs. Most interventions they reviewed were asynchronously delivered with little to no real-time contact with trained professionals. Overall, 45% of programs lacked cost-effectiveness data, and of those that did, only 18% were cost-effective. What this results in is many programs that produce short-term benefits that don't last, especially for people with multiple chronic conditions. So what is the Pictou County Personal Empowerment Program? Where other programs are short, narrow, and disconnected, PEP is long, comprehensive, and built to promote sustainable behavior change. It's the world's longest running program of its kind at 6 months in duration, and it's delivered in a hybrid home-based format. It's expert-led, multifaceted, and integrates both physical and mental health support with continuous professional and community engagement. Participants in the program will receive a daily email for 6 months, and the email contains a 3 to 5 minute video message from the two leads in the program, Dr. Ilia and Dr. Rutledge, and they prescribe activities for stress reduction, physical fitness, intimacy and connection training, social support through monthly video conferences and a participant buddy system, and dietary recommendations, to name a few. This comprehensive structure aims to fill the gaps of the existing interventions, and it may better support engagement in the program and lasting behavior change. That brings us to the aim of the thesis, to evaluate the cost effectiveness of the Pictou County PEP among adults with chronic conditions in Pictou County, Nova Scotia, from a healthcare payer perspective. So to address this research aim, we broke it down into 4 objectives. The first was to estimate the effectiveness of the program in improving psychological distress. Second, to estimate its effectiveness in improving quality of life. And third, to estimate the change in healthcare use costs before and after enrollment in this program. And fourth, estimate the cost effectiveness of the intervention in terms of its ability to reduce psychological distress and improve quality of life. To address these research questions, we used a single-arm prospective cohort study linked with administrative billing data. We used a pre-post framework where each participant serves as their own comparator. The Pictou County PEP Phase 2 feasibility study used online health questionnaires to collect outcome data at baseline, which was enrollment in the study, at 6 months, which was the end of the intervention, and then another 12-month follow-up. And within those online health questionnaires, there was a measure for the primary outcome of the trial, which was the Kessler Psychological Distress Scale, and a variety of secondary outcome measures, one of which was the Quality Adjusted Life Years measure. This analysis examined healthcare costs over a 1-year time horizon following enrollment in the program. So we're comparing healthcare use costs 12 months before versus 12 months after, and in a shorter time comparison window of 6 months before and 6 months after. The effectiveness outcomes were assessed by comparing the baseline measures to those obtained at 6 and 12-month follow-ups. 236 people were screened for eligibility in the program between December 2023 and January 2024, and ultimately 182 Pictou County residents with one or more chronic medical conditions were enrolled in the program. Of that 182 initially enrolled, 151 were included in our baseline analytical sample because 31 withdrew their consent for us to use their personal health information at the time where we were linking the survey data with the billing data. At 6 months, this dropped down to 107, and at 12 months to 112. So the K10 scale has been recognized as a reliable measure of psychological distress in both general and clinical populations, making it an appropriate outcome for assessing improvements in mental health among individuals with chronic disease. And therefore, this is the primary outcome of the Pictou County PEP trial. K10 scores range from 10 to 50, and our primary analysis treated these K10 scores as a continuous outcome. We also analyzed in a supplementary analysis the K10 scores in a binary case status indicator, where the following cut points, less than 20, indicating the probable absence of psychological distress, and a score of greater than or equal to 20, indicating the presence of non-specific psychological distress and need for clinical treatment. Our secondary effectiveness measure is the Quality Adjusted Life Year, or the QALY, and it's a function of health-related quality of life and quantity of life. It's measured in health utilities, which represent the strength of an individual's preference for different health states, and it's anchored between 1 and 0, 0 representing death and 1 representing perfect health. The economic analysis perspective that we adopt in this study is that of the healthcare payer perspective, which is defined as only considering monetary costs paid by a healthcare payer. And in our study, we estimate this healthcare payer perspective using Nova Scotia Medical Services Insurance physician billing data. So these costs represent physician-billed healthcare services, and they were used as a proxy for the frequency and intensity of publicly funded healthcare use. Costs not captured in this data are hospital facility costs, prescription medications, and other fees for health professionals like nurse practitioners or psychologists. All visit costs were included in our primary analysis, and a sensitivity analysis was subsequently done where we excluded billing code categories that were plausibly unrelated to chronic disease management to see how our cost effectiveness estimates changed when we restrict the visit types to those that are more related to chronic disease management. We used an available case approach where each participant contributed outcome data at the time points where their assessments were observed. So for example, if a patient had a baseline measure missing 6 months and at 12 months, we would include them in our 12-month analysis, and vice versa for someone with baseline in 6 months and not 12. They would be included in our 6-month analysis. We observed approximately 37% missingness in our two effectiveness outcomes, the K10 scores and the QALYs, at each of our follow-ups. And to investigate this, we first compared participants who completed their follow-up with those who didn't. And we looked at their baseline characteristics, and what we observed was that the two groups were broadly similar across their baseline characteristics, with one exception, that the baseline psychological distress measure for non-completers was slightly higher than those who completed their follow-ups, with a mean baseline K10 score of around 22.6 compared to just under 20 for completers. This overall pattern, where we have missingness that's associated with the observed baseline information rather than the unobserved follow-up values themselves, would be what we expect under missing at random assumption. So these statistical models that we used would be consistent under a missing completely at random assumption. However, they may be biased under the missing at random assumption, because you can think of it as we're systematically not capturing the follow-ups for those who had higher baseline psychological distress. And in our primary analysis, where we're doing this available case approach, we're not capturing those follow-up values. So to investigate this further, to see if those primary analysis estimates are biased in that way, we did a sensitivity analysis where we used multiple imputation under chained equations, and we imputed the missing effectiveness outcome measures at 6 and 12 months using the baseline information to predict those values. And what we observed was that the estimates were consistent with our primary analysis findings in terms of the direction, the magnitude, and the statistical significance of those findings. We did see that the K10 improvements attenuated slightly, and the health utility models essentially remained the same. So all that to say, the sensitivity analysis supports our use of the available case approach for our primary analysis. Generalized estimating equations were used to estimate population averaged within subject changes in our effectiveness and cost outcomes. So we used, for both of our effectiveness outcomes, the K10, change in K10 and change in health utilities over time, we used a Gaussian distribution identity link setup with an exchangeable correlation structure for both of these outcomes. And for our cost models, we used a gamma distribution log link setup with an exchangeable correlation structure to account for the right skewed distribution of those cost data. We adjusted for a predetermined set of baseline covariates in all of our models to improve precision in our estimates and adjust for participant characteristics that are associated with baseline health status, outcome trajectories, and healthcare costs. So I want to mention that this is an exploratory cost effectiveness analysis, and it's conducted using a modified pre-post framework rather than a conventional between group comparison that's often seen in these trial-based economic evaluations. So what that means is that our incremental cost effectiveness ratios really reflect differences in cost and outcomes, or effectiveness outcomes, at our follow-ups relative to baseline measures. And for our costs, the difference between the cost before program enrollment and after program enrollment. And these incremental costs, which is our numerator, and incremental effects, which is our denominator, were derived from those generalized estimating equation models as adjusted within participant changes over time. To explore the uncertainty around that, or those ICER point estimates, we first use a Monte Carlo simulation of the sampling distribution of those generalized estimating equation coefficients. And second, we used a non-parametric bootstrap where participants were resampled with replacement and the GEE models were refit in all of those replicates. What this produces is cost effectiveness planes and acceptability curves, and those acceptability curves can be used to estimate the probability that the intervention is cost effective across a range of willingness to pay thresholds for those health improvements that the program is generating. To elaborate a little bit more on those two uncertainty approaches, first, the simulation-based uncertainty, it draws from the robust sandwich covariance of those models themselves. So you can see here and think of this center yellow dot as the beta coefficient that the model will spit out to you in the output. And the spread around it is equal to the robust sandwich covariance of that model. And in each of these simulation draws, we're drawing one beta, say, from the K10 model covariance, and then we're taking another one from the cost model, and we're pairing those together in this cost effect change ratio in terms of the ICER and plotting it on the cost effectiveness plane. And we do this 2,000 times, and we get a really nice visual distribution or visual representation of the joint uncertainty in those change in cost and change in effect estimates. The bootstrap works from the other end, and it resamples the individual data rather than the coefficients from the models themselves. So you can think of this line at the top here as the original sample. And in one bootstrap replicate, we will sample from this population, and not everyone will be chosen. Some people will be chosen more than once, and then we will refit all of our models in that subpopulation and compute those marginal contrasts to get our change in cost and change in effect pairs and plot them on that cost effectiveness plane. And we repeat this 1,000 times, and we get that same nice visual representation of the uncertainty in those cost effect ratios. Okay, so that's enough background and methods. I will now get into the results of this thesis. So to start off, let's look at the baseline characteristics of this prospective cohort that we followed. And overall, this was a very clinically complex, predominantly rural, predominantly female multimorbidity cohort. Almost 60% of the population was classified as obese, 41% were taking medication for anxiety or depression, over half lived in rural communities, the median number of chronic conditions was 3, and this ranged from 1 all the way up to 11 conditions. The mean age was just under 60, and almost 90% of the cohort was female. The cost to deliver this intervention to the 182 participants enrolled came out to $57.92, and this is broken into participant materials, mailing materials, and research coordinator time. Looking at our effectiveness analysis results, what we observed were statistically significant and sustained reductions in psychological distress scores at 6 and 12 months relative to baseline. And looking at our health utility models, we see improvements in health utility at 6 and 12 months relative to baseline that translate into net positive quality gains at both 6 and 12 months. Our cost analyses showed no statistically significant pre to post differences in adjusted mean healthcare costs per person comparing before and after enrollment. So we are not seeing meaningful cost increases driven by the program or cost decreases driven by the program. And if you take a look a little bit closer at these plots, you'll see that in both post periods, 6 months post and 12 months post, there's a slight increase in healthcare costs in that post period. And when you take into account the cost to actually deliver the intervention itself, that $57 estimate, you get a incremental cost per person of $105 at 6 months and $115 at 12 months. Overall, this is a very low cost intervention with a very small downstream cost increase in the first year. Combining our cost analysis results with our effective analysis results gives us these incremental cost effectiveness ratios. So looking at our reductions in psychological distress, per 1 point reduction in K10 score, we're paying around $37 per point reduction at 6 months and $35.32 per point reduction at 12 months. Now looking at our quality ICERs, we see that at 6 months, it is around $16,000 per quality gain, which drops all the way down to around $5,300 per quality at 12 months. And just for reference, the commonly cited Canadian wills to pay range for a quality gain is between $50,000 and $100,000 per quality. Now looking at the uncertainty around those quality-based ICERs. So these are our cost effectiveness planes, and on the left is our 6-month analysis, and on the right is our 12-month analysis. And what we see is that at both time points, all simulated cost effect pairs fell in the 2 right-hand quadrants corresponding to positive quality gains. And at 6 months, 95% of the pairs fell in the northeastern quadrant, or the top right quadrant, corresponding to greater effectiveness at a higher cost in that post period, which is what we'd expect based on those cost analysis results. And the remaining 5% land in that bottom right quadrant, corresponding to greater effectiveness at a lower cost in the post period. The corresponding percentages at 12 months were 85.8% in that top right quadrant and 14.2% in that bottom right quadrant. So slightly more in that cost savings and cost in effect generating quadrant. So as I mentioned, those cost effectiveness planes can be translated into these cost effectiveness acceptability curves. And these are really useful for estimating the probability that the intervention is cost effective at a range of willingness to pay thresholds. So you can imagine that you are a member of a health technology assessment agency and you're considering funding this digital chronic disease management program, but the maximum amount of money you're willing to spend per quality gain is $50,000. So you can come look at this plot and see, okay, $50,000 per quality, and then you can see what the estimated probability that the intervention is cost effective. And at 6 months, it comes out to 95.5%, and at 12 months, it reaches 100% at that 50,000 willingness to pay range. Both of our quality ICER estimates sit well below the figure most often used to contextualize value in Canada, that $50,000 per quality benchmark. A 2023 review of chronic disease management programs showed that effective programs range between $10,000 to $50,000 per quality gain, so our 12-month estimate sits entirely outside of that range, and our 6-month estimate sits in that lower portion. It's also worth mentioning that the $50,000 per quality benchmark is not a strict decision rule. Canada's drug agency has no formal threshold, and a review of almost 300 CADIT appraisals found that the figure is used informally but applied inconsistently, with recommended submissions ranging from cost dominant all the way up to $130,000 per quality gain. Additionally, I want to mention that the estimates from this thesis come from a single-arm design, while most of the comparators in that 2023 review come from controlled trials or decision models. So this is a comparison in terms of magnitude rather than a like-for-like comparison. It's also important to place the Pictou County PEP in the context of the program from which it was adapted, the Prostate Cancer Patient Empowerment Program. And this PEP program began with prostate cancer patients. It was tested in a crossover randomized controlled trial where waitlist controls had 3.6 times the odds of distress requiring clinical treatment, and it was found to be cost-saving in a published economic evaluation this past year, where the program was dominantly cost-effective, saving around $660 per patient per year. The program is now part of standard of care in Nova Scotia and is scaling across the provinces and internationally. So the Pictou County PEP builds on this evidence base and asks the question, when the PEP program is tailored for chronic disease management in this rural population, does the effect translate? And this study is one of the first steps to try to answer that question. Okay, so what did we observe? Participation in the Pictou County PEP was associated with sustained improvements in psychological distress and health-related quality of life. Healthcare costs remained stable, so total incremental costs ranged between $105 and $116 per person, which was largely driven by that $57 intervention delivery cost. And the program was associated with favorable cost effectiveness. That $5,300 per quality gained at 12 months sits well below the Canadian conventional benchmark. Our cost effectiveness estimates were robust to joint uncertainty. All of the simulation draws and bootstrap replicates indicated improved effectiveness, and the probability of cost effectiveness exceeded 95% at that $50,000 per quality range. Okay, so how do we interpret these results? I want to mention again that this is a single-arm pre-post design, so these results must be framed as associations rather than causal effects. Our estimates are likely conservative given the cost data that was captured, which I'll elaborate on in my next slide. And overall, this thesis generates the preliminary economic evidence needed to justify a definitive controlled evaluation of Pictou County PEP in the future. And that brings me to the strengths and limitations of this work. This evaluation was among the first economic evaluations of a multi-component, home-based self-management program for multimorbidity in rural Canada, and rural Nova Scotia specifically. We use administrative cost linkage rather than relying on self-reported healthcare use costs, so this avoids any recall bias. We use two outcomes, one condition-specific and one preference-based, which allows us to compare with the broader literature. We use appropriate statistical techniques to model within subject changes in cost and effect estimates, and we robustly quantify the uncertainty around our cost effectiveness estimates using both Monte Carlo simulation and bootstrap techniques. The study was conservative by design, where we include all visit types and we use a full research delivery costing in our primary analysis. This study is, however, not without its limitations. The single-arm design means that we cannot rule out the role of secular trends, so these findings are associations. The sample is predominantly female and white, so it limits our ability to generalize these findings to another population with different characteristics. And the billing data, or the cost data that we're relying on, is from the medical services insurance billing data, and it only captures physician-billed healthcare services, which only makes up around 14% of public healthcare spending. So if the program works as we hypothesize it does, where we're helping patients better improve the management of their conditions and shift away from the costly downstream inpatient hospitalizations and emergency department visits that would result from poorly managed conditions, and we're shifting that towards a more primary care approach. So we capture the increased visits to a primary care physician, and we're not capturing the avoided emergency department or hospital inpatient facility fees. Additionally, the 12-month time horizon is far too short to truly accurately measure the potential cost offset that typically follows behavior change interventions like this program. And lastly, the missing data piece. So with the non-completers having a slightly higher distress score, means that the effectiveness estimates may be slightly overestimated. However, through the imputation analysis, we see that this concern is largely mitigated because our sensitivity analysis results are very consistent with our primary analysis findings.